Okay, welcome to Grand Rounds. We're going to get started. I think there'll still be some trickling in, but we'll go ahead and let Dr. Vu get started. So our Grand Rounds today is anticoagulation in pregnancy. This is Dr. Vu, our Chief Resident.
Hi, for those of you who don't know me, I'm Dr. Vu, or who haven't been through clinic yet. But this topic came out of a suggestion by Dr. Groom during one of our Friday morning, where we would kind of review how we got our recommendations for these anticoagulations in the special population in pregnancy, and where our ACOG recommendations comes from. So the objectives of this is to review the safety and effectiveness of anticoagulation in pregnancy, to discuss the risk of clotting in special populations, and provide recommendations for anticoagulation, and then discuss the pregnancy and the fetal complications in those special populations, and provide recommendations for preventing and screening. So this is the Clotting Cascade that y'all seen in medical school. So the main thing that we want to look at is this extrinsic pathway here, where trauma to the endothelial cells will release this tissue factor from the endothelial cells, which would help bind to factor 7 to activate factor 10, which is prothrombinase, and factor 10 and factor 5 together will cleave prothrombin to thrombin, and then fibrinogen to fibrin, and make that fibrin cross-link. So we have our natural anticoagulants. There's tissue factor inhibitors. There's antithrombin that inhibits thrombin and factor 10. There's also a molecule called thrombomodulin that is produced downstream in uninjured endothelial cells that binds to protein C and then activates it so that it can inhibit 8 and factor 5 right here. And then protein S helps enhance this reaction that protein C does. So the anticoagulants that we're talking about are the vitamin K antagonists. These are the ones that target the vitamin K dependent factors, which are, 2, 5, 7, and 9. The heparin, which bonds to antithrombin and helps potentiate its effect. There's also the direct thrombin inhibitors, and then there's the direct factor 10 inhibitors also. So there's a lot of anticoagulation regimens. We're not going to go through this, but there are adjusted dosing between unfractionated heparin, and then there's different types of low molecular weight. There's also an intermediate dosing to low molecular weight, and then there's a prophylactic dosing. So now we're going to go through the safety of it. So the bleeding risk was quoted by Ginsburg in 1989, where he did a retrospective study of 77 women, and he found the major bleeding risk for unfractionated heparin to be 1 to 2%. And he defined major bleeding as either bleeding into an intracranial site or retroperitoneal or any other, as well as a drop in hemoglobin below 20 grams per liter, or anything that required transfusion of 2 or more blood, packed red blood cells. And this rate here is comparable to the rate in non-pregnant patients as well as the patients taking warfarin. The incidence of heparin-induced thrombocytopenia was looked at by Workington in 1995, where he did a double-blinded trial of comparing unfractionated heparin to low molecular weight heparin. And he did daily platelet counts, and he defined HIT as whenever the platelet counts fall below 150K and 5 or more days after the start of treatment with positive antibodies. So he noticed that the incidence rate of HIT in those receiving heparin was 2.7, or 9 out of 332 patients. Just a side note, he didn't see any HIT in those that had low molecular weight heparin. So there's also a risk factor of osteoporosis, because In Duquetis in 1996, he showed that he did a prospective cohort where he looked at the long-term effects of it on bone density. And he saw that there was no fracture, but there was a significant reduction in bone density in those receiving unfractionated heparin versus those that didn't. But there wasn't any correlation between the lumbar density and the dose and duration of heparin. There was also another study by Dahlman who through a decade from 1980 to 1989, where he looked at women receiving long-term anticoagulation with unfractionated heparin, and in that study there was a 2.2% of osteoporotic fractures in that study group. Another risk of unfractionated heparin is the skin reaction. So you can see here the erythema swell, circumscribed lesions, the skin necrosis, the diffuse rashes and all that. But the true incidence of it is unknown. But it is, because it is immune related, it is very common related to HIT. So this was the go-to anticoagulation before low molecular weight came into play. So Gold did a study meta-analysis in 1999 that compared whether the effectiveness and safety of low molecular weight to unfractionated heparin. He looked at 11 randomized trials, and what he saw was that in terms of mortality, there's a slight benefit that favors low molecular weight over 3 to 6 months, and there was also a favor of major bleeding risks too. In terms of recurrent thromboembolism, he just found that low molecular weight was the same at preventing recurrent thromboembolism as unfractionated heparin. So what he concluded that it seems just as effective as unfractionated heparin in the prevention of recurrent clots. Quinlan also did a meta-analysis, but he did it a little bit later than Gold, and he looked at pulmonary embolism at the end of treatment and those that had pulmonary embolism at the end of the treatment and 3 months after. And what he saw was that there is a decreased rate in the overall of thromboembolism between low molecular weight and unfractionated heparin at the end of the treatment, as well as at 3 months. And then in terms of recurrent bleeding, there wasn't any statistically significant difference between these major bleeds. So he concluded also that low molecular weight was just as effective and safe. So Lepere decided just to look at Lovenox in pregnancies mainly, and what he looked at was 49 women who had acute treatment of a clot, and then 570 women who had prophylaxis. And he looked at maternal safety in that the incidence of hemorrhage, thrombocytopenia, any hematomas at the injection site. And then he also looked at the fetal and neonatal safety, where the incidence of abortion, stillbirths, any congenital abnormalities were taken into account. So what he saw was that maternal hemorrhage occurred in about 11.5%. One was serious, and most of these were due to DIC, placenta previa, abruption, or sepsis, but the only one that was thought to be serious and related to Lovenox was epistasis, which they thought in someone who was taking 1 full dose Lovenox, and they measured the anti-10 levels, and it was elevated. The bleeding risk during delivery is 5.1% in that one of them was due to atonia, atony 8 hours after 40 milligrams of Lovenox, and one had a creta 14 hours after a 20 milligram dose of Lovenox. The rate of thrombocytopenia is 1.3, and then when it comes to stillbirth, The rate that's presented, 1.1, was consistent with the general population that they said. 4 of these were singletons, 4 of these were multiples, and there were a lot of causes, including growth restriction, choreo, abruption, and 1 was due to twin-twin transfusion. None of them was related to Lovenox that they found. The congenital abnormalities were also 2.4% was comparable to the general population also, and then the rate of neonatal hemorrhages, and none of these seem related to the Lovenox use. So, when Sampson did his study, he did a systematic review, and he divided women into 2 groups who were receiving Lovenox. Those with comorbidities, where that was defined as any condition that could potentiate a adverse outcome in pregnancy versus without comorbidities. And he looked at fetal outcomes that included abortion, stillbirths, any congenital abnormalities, or if neonatal outcome was poor. And of these, he noticed that there was increased incidence of adverse outcomes in those with comorbidities. There was also an incidence of clotting out of 3 out of 486, and also allergic reaction. Of the women, of the 3 who had the incidence of clotting, 2 had a thrombophilia that was confirmed, but not specified which, and 1 had antiphospholipid syndrome. So, Greer also did a systematic review of how safe and effective Lovenox was in pregnancy, and what they saw was that there was no incidence of maternal death, but the incidence of thrombosis was 1.3%. There was no significant bleeding with the rate of almost 2%, and then the allergic reactions were around 1.8. Of note, the percentage of developing osteoporosis fractures was 4.4%. So, segue into how low molecular weight affects osteoporosis. So Rogers did this study where he wanted to see if long-term dalteparin or leads to bone loss, and he basically compared those who received antepartum prophylaxis with dalteparin versus those that did not have antepartum prophylaxis, and then all of these women had 6 weeks of prophylaxis after. So what he ended up was 33 women in the antepartum group and 29 in the postpartum group. And the results down here, as you can see, there is not a lot of difference between the bone mineral density in the hips, and there is not a lot of difference in the T-score spine. So the bottom line is that low molecular weight is equally as effective as unfractionated heparin to prevent recurrence. It has less bone loss. It also has a decreased rate of major bleeding. So what the American College of Chest Physicians recommends is that it should be used to prevent and treat thromboembolism instead of unfractionated heparin. If you remember the first slide, it also has a decreased incidence of heparin-induced thrombocytopenia too. So what about fetal complications? So when we talk about this, we're talking about the Recurrent embryopathy that's associated with warfarin, where there's some nasal hypoplasia, and there's skeletal stifling, as well as any CNS abnormalities that include hydrocephalus, mental retardation. So Chan did a study where he wanted to see what the maternal and fetal risks were, where there were 3 regimens that the women were divided into: those that received oral anticoagulants throughout pregnancy, those that had heparin first and then was switched over to oral anticoagulants, and then those that had heparin only. And what they found was that the incidence of warfarin embryopathy was about 6.4%, and to those who used it throughout pregnancy. And there was no difference in the risk of spontaneous abortions, where it's around 24%. So they found that the overall risk of neonates in were the same between patients undergoing oral anticoagulants throughout pregnancy and those who had heparin initially and those at the end. In the case where heparin was substituted at the beginning, they noted a 3.4% chance of congenital anomalies, but interestingly, they did not see it in patients that had heparin that was started before 6 weeks. So Schaefer also did a prospective study on comparing the exposure of anticoagulants in women versus those that were unexposed. And they saw that the major birth defects after trimesters were increased with an odds ratio of 3.89. Now this multi-center was all in Europe, so they have different types of oral anticoagulants used, because we use warfarin here in the States. But there's also different types that include fenprocuman, acetocumarol, fluindamide, and phenadione. And they noted that the coumarin embryopathy was only found in those exposed to fenprocuman. They also saw that there was an increased risk of prematurity, but the miscarriage rate with exposure was essentially the same as what Chen found. So with low molecular weight heparin and unfractionated heparin, there isn't a lot of evidence against teratogenicity or increased fetal bleeding, so that's why it's safe to use. With these newer anticoagulants, the danaparanoid, which is a heparin-like substitute, and then the pensaccharides and the oral thrombin and anti-10 inhibitors, those are limited evidence. In aspirin, there was a study done by ASCI in 2007 that did a meta-analysis around about 32,000 women and their babies in a randomized trials, and they saw that there was no effect on either fetal or neonatal death, small for gestational age, or bleeding events in between mom and baby in those patients taking aspirin. So what the recommendation is that in women receiving the treatment for blood clots, the low molecular weight is preferred over vitamin K because of its better profile. There's limited use of the new anti-10 inhibitors and any other thrombin inhibitors to those who have severe reactions like HIT to heparin that cannot receive the danaparanoid. And then you avoid the use of the direct thrombins and anti-10 inhibitors. So when we look at breastfeeding, warfarin is found in a negligible amount in infants and breast milk. It was quoted that in women who've had therapeutic levels of warfarin, they found that there was no levels found in the infants versus minimal amounts that were found in breast milk that range from 0 to 0.08 micromoles per liter. Unfractionated heparin is negatively charged, so it doesn't go into the breast milk. And then there's low bioavailability. It doesn't absorb well between low molecular weight, danaparanoid, and arhiridin. So those absorption is poor, so even if it gets into breast milk, the baby's not going to absorb it through into its system. And then there's no data on these new ones down here. So if you're on aspirin, it's excreted into milk as salicylate. So Barros did a study on whether, and he showed that there was 4 to 8% that reaches maternal dose that reaches the infants, and then these levels appear 3 to 9 hours after ingestion, and the baby clears it away a lot slower than the mom. So if they're on low-dose aspirin, there's no issues. However, there have been case reports of TTP and metabolic acidosis in infants who've been exposed to a mom taking a high dose of aspirin, like 3.9 grams a day. So there's a theoretical concern that can cause, that can impact the infant and affect the clotting factors. So the take-home message is that low molecular weight heparin and warfarin is safe to use in breastfeeding. There's limited data on the newer anticoagulants, and that low-dose aspirin is safe, but in those high dose, you just have to caution the mother and monitor the infant for any signs. So now that we've kind of run through the safety of these anticoagulants, we're going to talk about them in special populations and their usage. So compared to the antepartum period, the postpartum is where most of the clots occur. It's the highest risk. It's about 2 to 5 times more common postpartum, especially with one of the risk factors being C-sections. Other risk factors can include obesity, postpartum hemorrhage, AMA, hypertension, smoking, and that's in a lot of our patients. Gurman in 1999 did a retrospective review, and he found that most of the PEs occur in the postpartum period, 2 out of 38, which is 60.5%, and it was strongly associated with C-section, where that was statistically significant. So to prevent this, there was a Cochrane review to see the effectiveness of low molecular weight heparin versus unfractionated heparin versus no treatment. And they found that there was no statistically significant difference between symptomatic blood clots between heparin versus no treatment. And the relative risk is right here. You can see 5 out of 402 versus 4 out of 428. When they compared low molecular weight to unfractionated, they saw one thrombolic event in the unfractionated group. Blondin did an interesting study where he constructed a decision model to see whether it was beneficial to anticoagulate patients after C-section. So this was his example. So this first case here, this is a woman that has no risk factors. Her BMI is less than 25, she is non-smoker, and she is having a normal vaginal delivery. So the risk of having a clotting event without prophylaxis is around 5,000, and then right here, around 2,500. But if you prophylax them, which is this bar next to it, then the rate drops by 1,400. However, the bleeding risk is still around like 900. So if you take the same woman and you give her an emergency C-section, then you can see that her risk of blood clots increases. But her risk of bleeding is relatively the same. So there's an extra 3,000 more thrombotic events in the same lady with an emergency C-section. So they concluded that to prevent one episode of VTE, one episode of major bleed would to risk 2.5 more blood clot events. And so this third case is when they took a woman that was obese and a smoker who had a vaginal delivery, and as you can see here, the risk without thrombophilaxis greatly increases. And if you put her on low molecular weight heparin, this decreases her blood clot events to 11,000. And her bleeding risk is still the same. The bleeding risk with all of these are relatively the same, if you can just see the heights of these bars. But if you give this obese woman who's a smoker a C-section, then her risk goes beyond 18,000. Yeah. So to put her on a low molecular weight heparin is to prevent greater than 23,000 events of blood clots from occurring in 1 million patients. And so they calculated their number to treat is 440 in patients who have this high risk profile. And to prevent, and then if you add heparin onto it, this can prevent 40 blood clot events for each bleeding event. So what he concluded was that it was beneficial to start it in those patients that are high risk. So this is a meta-analysis of all the prevention of and major bleeds before symptomatic blood clots with or without prophylaxis. And you can see here for the low risk is up top here. There is 5 events without prophylaxis, and then there's 3 fewer. So there's not a lot of gain in there. But for someone who is high risk, and these risk factors down here, if you have one of these major risk factors, your risk of having a blood clot is 3%, and that includes if you're on strict bed rest for more than a week, if you have any of these thrombophilias, if you've had a blood transfusion or postpartum infections. You need 2 of these minor risks to develop a risk of developing clots greater than 3%, and that includes obesity over 30, the BMI over 30, if there are multiple pregnancies, if they've had a hemorrhage, if they're smoking more than 10 cigarettes. So in these high-risk patients, the event is 40, and then there's actually 21 fewer events whenever heparin is started. And major bleeding risk is essentially the same between those with prophylaxis and those without prophylaxis. So what they recommend is for those who have no risk factors, after C-section, they just encourage early mobilization. Those women who have at least the presence of 1 major or 2 minor risk factors, they discuss doing pharmacologic, like heparin, prophylaxis, and if they can't take it because there's some kind of contraindication, you can do mechanical. So the thing with mechanical prophylaxis is that, of course, you are decreasing the event of major bleeding, but you're also increasing your risk of developing blood clots. In high-risk women, there could be 24 more events and 7 fewer bleeding. So you have to just weigh the risks and benefits. In very high-risk women who have multiple additional factors, they just recommend the low molecular weight heparin with the elastic stockings or the intermittent compressions. And then significant risk factors, they recommend prophylaxis at least 6 weeks following discharge. So we're going to go through how to treat the acute blood clot in pregnancy. So the incidence of blood clots in pregnancy ranges from 0.6 to 7.1 episodes per 1,000 deliveries. So it's not that frequent. Ray saw that in his meta-analysis, he saw that most of it occurred in the 3rd trimester, and then there was a little peak in the 2nd trimester as well. And so to treat this ladies with vitamin K antagonist versus low molecular weight heparin, this shows that with the risk factors with vitamin K in these women is 30 events versus if you start them on Lovenox, it's 11 fewer. And then there's also fewer bleeding events with the Lovenox too. And so what they recommend is heparin over these vitamin K antagonists just because they have a more predictable response and a better response, and then there's improved maternal safety. So if you can't use low molecular weight heparin for some reason, like in patients who have severe renal disease, unfractionated heparin is the option. And you can do 2 alternatives where you can do an IV followed by adjusted dose sub-Q every 12 hours, or PID adjusted dosing. And then you check a PTT 6 hours after injection in mid-interval to see if it's in therapeutic range or not. There's no studies that have addressed the optimal duration of treatment for acute VT. Kieran, who was the first author in the CHEST recommendations for non-pregnant patients, said that a minimum duration of 3 months for any blood clot that was either provoked by surgery or non-surgical transient risk. So with that added on to the pregnancy risk for blood clots, they recommended treatment throughout pregnancy and into the postpartum period for a duration of 3 months. So what happens at delivery? So you don't want to have a woman on full dose Lovenox and you're about to deliver her because she has a good chance of hemorrhage. So they recommended to discontinue any BID dosing 24 hours before induction of labor or C-section. And those taking daily low molecular weight heparin should take 50% of their dose on the morning before delivery. If you check your PTT and it's markedly prolonged, then they recommend the use of protamine sulfate. They considered women who were very high risk if they develop a blood clot within 2 weeks of delivery. And in those women, you want to minimize the time between their off anticoagulation. So what was recommended is you put them on IV heparin and then discontinue it 4 to 6 hours prior to delivery or epidural insertion. So what to do with women who had a prior clot or a prior DVT or PE? So Brill did a prospective study in 125 women who had a previous blood clot and their antepartum prophylaxis was withheld and they were given postpartum prophylaxis. 95 of these women had blood drawn and about 48% of them had an abnormality in their thrombophilia workup. So just keep that in mind. He saw that the rate of recurrence was 2.4% in the antepartum period and then 2.6% in the postpartum period. So Pavinger did a retrospective cohort study where he wanted to assess in women with previous blood clots what was the rate of recurrence. So these 59 women underwent lab work to see if they had thrombophilia, and if they did, they were encouraged to discuss prophylaxis with their primary OB provider. So what he found was there was 8 recurrence in 197 in those who did not have any prophylaxis. So here you had 197 women, and then there was eight events. In those with prophylaxis, there was none. And after pregnancy, as you remember, there's that increased risk of blood clotting that there were a total of 15 blood clots, and the percentage most is in the stillbirths. There's still a 6.5% risk if you have a live birth. So they concluded that without Lovenox or any sort of thromboprophylaxis, the recurrence rate is substantial during delivery and especially in the postpartum period. Stefano also looked at the recurrence rate in his retrospective cohort, and he saw that of this 155 pregnancies in 88 women, these had 19 recurrences, which gave a recurrence rate of 12.2. Most of them occurred in the postpartum period. And he quoted a 15.5 recurrence rate in women with their first blood clot from pregnancy. Now, just keep this in mind that of these 88 women with these blood clots, only 40% of them had their blood drawn and had inherited thrombophilia. So this number is kind of skewed towards that. So White also looked at the risk of recurrence, and he quoted the risks of recurrence in women who had their first pregnancy-induced blood clot. The recurrence rate of that is 10.4 of those versus 5.8 in women who had unprovoked blood clots. And so the overall, even though the overall risk of recurrence is low in women with a prior blood clot due to an unprovoked cause, the risk is high if the initial blood clot was seen in pregnancy. So this is a systematic review of the evidence of why we anticoagulate these people. In that, in low-risk patients with transient risk factors like a recent hospital stay, immobilization, any trauma, the decrease with Lovenox is 13 fewer, but in those with intermediate or high risk, which is pregnancy or estrogen related, with multiple prior blood clots, the decrease is more significant, is 80 versus 51. And then there was no significant difference in major bleeding events whenever prophylaxis is started. So again, Lovenox is a preferred prophylaxis. In women who have indications to do this for long-term, vitamin K antagonists is recommended, especially if they've had multiple episodes of blood clots and are considered high risk. And these should be resumed as soon as delivery is completed. So, is repeated screening for DVT a good alternative to prophylaxis? And the answer to that's no. So, if you look at the rate of recurrence of blood clots to be 5%, and given the sensitivity and specificity of an ultrasound, there's approximately 28% of false positives in there. So there's also no evidence to guide the timing of screening, and any recurrence could occur in between the time you last ultrasounded them and then the next time. And but it's a good idea in someone who's had a previous clot in their leg, because it can help distinguish between the residual clot and any new blood clots that are forming. So now let's talk about the prevention of blood clots in women who have thrombophilia and no prior history of blood clots. So this is an estimated pool risk, and it's going to be smaller in just a second. So as you can see here, there is a significantly increased risk of blood clots in these women who have thrombophilia. The most significant risk is in those who are homozygous for factor V, Leiden, and prothrombin mutations. And then the lower risk are those with the protein S deficiencies. If you keep in mind this, the incidence of baseline blood clots in pregnancy to be about 1 per 1,000, like we mentioned, there's an absolute risk in these women for most thrombophilias, but the baseline risk is increased to about 4 to 5% in women who have these factor V, homozygous Leiden, and homozygous prothrombin. So when you compare them to those with a family history, the positive family history increases your risk about 2 to 4-fold. So as you can see here, that every odds ratio or absolute risk is almost doubled, and even in factor V homozygous, it went from 5 to 14. So women who have this inherited thrombophilia with a positive history have a 14% chance of clotting in their first pregnancy, versus those who have protein S or protein C deficiency have a 1.7% clot. But just take note of these wide confidence intervals, in that it's because of the rarity of these thrombophilias, it's not as precise of a calculation. Interestingly enough, we've all heard that antithrombin deficiency used to be categorized as high risk based on older studies of recurrent blood clots, but these studies in the blood clots were never really confirmed. But recent studies show that it's not as high risk as previous. So what they concluded was that the absolute risk for blood clots in women without a prior clot or family history remains low. It's the baseline risk that everyone has, except it's a little bit elevated, except for those with homozygous factor V or prothrombin mutations. So to prophylaxis, it's only indicated if you are homozygous for factor V or prothrombin, regardless if they have a family history or not. For those who, for the other inherited thrombophilias, with the family history, then that's when you would want to prophylax them. antiphospholipid syndrome, there's an increased risk of blood clot, but this risk is uncertain in women who have had previous blood clots. So Quenby did his retrospective case control questionnaires where he hypothesized that women who've had recurrent miscarriages and diagnosed antiphospholipid syndrome are at higher risk than thrombosis than those who have just idiopathic miscarriages. So they had a pretty good response rate and they had a pretty good follow-up. So as you can see here, the number of thrombotic episodes between idiopathic recurrent miscarriages and those with antiphospholipid syndrome with recurrent miscarriages, these are relatively the same. There's an increased risk in those who have antiphospholipid syndrome with recurrent miscarriages, but it's not statistically significant. What is the fact that if that person had a thrombosis before you add that they had a history of blood clots in there was 100% recurrence rate in those 8 women. And interestingly enough, these 2 women who had idiopathic miscarriages, they underwent blood testing, and one was homozygous for prothrombin, and then the other one was heterozygous for factor V. So let's talk about the MTHFR mutation. So it's only associated with thrombophilia if there's hyperhomocystinemia involved. And so Tahir measured the plasma levels in 269 patients matched for controls, and what they saw was about 10% had plasma levels above 95, which is defined as 18.5, and then above the controls there was only 5%. Women had an increased risk of thrombosis as they age, where if you're less than 30, your odds ratio is 1, versus if you're greater than 30, then your odds ratio is 7. And they also noted that the risk of thrombosis didn't increase until you went above 18 micromoles of plasma homocysteine. So what this implies is that instead of being a relative effect, it's more of a threshold where thrombophilias increase. So Robertson did a meta-analysis of this where there was only 2 retrospective case control studies in his meta-analysis, and it's the first 2, Dilly and Grandone. Murphy had a prospective cohort study, and then GYN had a study that was confounded by women taking folic acid on top of it. So the odds ratio that he found in comparing these 2, when he reviewed these 2 studies, was that there was an 8.3% risk of clotting. They don't know if it's the mechanism behind it, but folic acid tends to reduce homocysteine levels, so there's that confounding factor. So if you have a woman who has a positive family history of blood clots and then is homozygous for factor V and prothrombin, the chances of developing a clot is 70 per 1,000. But if you put prophylaxis on top of it, there's 47 fewer events. And then if you look at the other ones with the low risk thrombophilia, you're not getting, your benefit runs from 10 to about 13 fewer events, with those without prophylaxis being around 15 to 20. So in terms of major bleeding, there's no significant difference if you prophylax them. So what they recommend is only in women who have a family history and no prior blood clots, and they're homozygous, they need postpartum prophylaxis as well as antepartum prophylaxis. For other thrombophilias, you can do clinical surveillance and then 6 weeks postpartum prophylaxis. Any of these that have no prior family history or no prior VTE, then and they're homozygous, then you can clinically surveil them during the antepartum period, but they need postpartum prophylaxis. And then all the other thrombophilias, you can just clinically vigilance to detect any developments of clots. So now we know that thrombophilia is associated with different complications. Antiphospholipid syndrome is related to a recurrence and pregnancy loss. So Opatry in 2006 did a meta-analysis of all these studies, and he found that the most significant factor was anticoagulant when associated with late fetal loss of 7.7. There's also some relation with IgG cardiolipin antibodies, so both early and late fetal loss, but beta-2 glycoprotein, they didn't find any association. And the higher their levels of titers are, the more associated they were to these recurrent fetal losses. There's less agreement on whether antiphospholipids is a risk factor for placenta abruption or preeclampsia intrauterine growth restriction. So this is a meta-analysis showing that the association between each thrombophilia and early pregnancy loss. Just remember that these confidence intervals are, again, really wide just because the thrombophilias are not as prevalent as other disorders. There has been an association between thrombotic disorders and miscarriages, but it's hard to kind of confirm whether fetal growth restriction or placental abruption is associated with these. So for someone who has antiphospholipids and then recurrent pregnancy loss, they wanted to look at whether if you add unfractionated heparin and aspirin to it, would it make a difference in live births. So they had 3 randomized control trials that they pulled into this meta-analysis, and they saw that there was 283 fewer losses per 1,000, but there's no significant difference between IUGR and preeclampsia. So their recommendations is in women with recurrent early pregnancy losses, just to screen for antiphospholipids, and women who have pregnancy complications in general but don't screen for it. Those women who fulfill the laboratory and clinical criteria of a history of more than 3 pregnancy losses, antepartum prophylaxis with Lovenox and aspirin is warranted. And then those women with thrombophilia and pregnancy complications, they don't recommend to prophylax them because of their pregnancy complications. So let's look closely at the preeclampsia and thrombophilia and whether antiplatelet therapy, which is low-dose aspirin, makes a difference in decreasing the amount of the events of it. So they classify this between low risk and high risk preeclampsia, and there are different factors like someone who has antiphospholipid syndrome and previous preeclampsia. They have a 7-fold risk of developing preeclampsia. But those who are obese, who had pre-existing pre-E twin pregnancies or family history, they have a 2-fold risk. So as you can see here, that adding low-dose aspirin to it can prevent there's 10 fewer cases versus 60 cases in those without platelet therapy. And then those women extremely high risk for developing preeclampsia, there's 200 cases without antiplatelet therapy, and then there's 36 fewer losses per 1,000. And then there was no increase in bleeding episodes. Actually, there's less bleeding episodes in those who were treated with low-dose aspirin. So this was a meta-analysis that wanted to see if whether adding low molecular weight and aspirin decreases your risk of miscarriages in 2 or more pregnancies. So this is at the top, and as you can see, there's no significant difference between there. The bottom table is summarizes the randomized control trial that in women who have had 2 or more unexplained miscarriages that they gave aspirin to. And so, again, there is no significant difference there. So what they recommend is for women who at risk for preeclampsia, low-dose aspirin throughout pregnancy starting in the 2nd trimester is warranted. And for those who've had 2 or more miscarriages and no antiphospholipid syndrome or thrombophilia, then don't prophylax them. So just for completeness sake, I'm almost done, I promise. In women with valves. So this is a study that I described earlier when we were talking about warfarin embryopathy and in the 3 different regimens with oral anticoagulants throughout pregnancy, oral, then heparin, and then heparin alone. And what they saw that the risk of thrombosis was lowest with vitamin K antagonists throughout pregnancy, and then it was highest if you use unfractionated heparin throughout pregnancy. So their recommendations is, as we discussed before, the risk of malformations are low if heparin is substituted for vitamin K antagonist in the 1st trimester, but there is a higher risk of pregnancy losses in women who receive vitamin K, if you can remember all the way back to the initial few slides. And so they recommend one of these regimens, which I'm not going to go through because they're really complicated. And so for those who have high-risk thromboembolism, like those who have the older generation valves, they recommend vitamin K throughout with aspirin. And then switch over to heparin closer to delivery. So before you start anticoagulation, you got to think about what the patient is thinking. So the women take into these considerations that they are pregnant and they're going to breastfeed their baby. So giving them anticoagulants has some implications for them. And then rather, a lot of women don't see their pregnancy as a medical condition, just a normal part of healthy life. So they take into account a lot of factors that include how often you're going to inject them, or how often you are going to need to test them and do blood work, or how often you need to take this medication, or any side effects. There are no studies that addresses a patient's preference to starting therapy, but in clinical experience, a lot of women will choose long-term prophylaxis just because they give higher priority to the health of their child, their unborn child, than on themselves. So it's sort of you have to optimally counsel the patient before a decision is made. That's the main one. That's it. Sorry, I kept dropping this microphone.
She's been taking notes, so I imagine she's got a lot of questions.
That is extremely thorough. Well done. Did you look at as far as planning delivery and optimizing delivery times when you've got women on these medications, forced inductions, was there increased risk of C-section? So like when you've got somebody on anticoagulation and you're going to have a planned delivery, because we want to optimize their anticoagulation, either switching them over or holding it and inducing them, do they have an increased risk of C-section? Or did you come across anything like that?
Well, there is those are the studies that I mentioned that have the bleeding risk during the delivery, and even though the bleeding risk is really rare, it's recommended to hold it because most of those bleeding risks are within patients who didn't have enough sufficient time for the Lovenox to be dissolved.
Did they have a higher C-section rate?
Oh, I don't know.
That was very good. And I hope everybody saw the complexity of managing And there's no way you can retain all that information about what to do this and what to do that. And a lot of this comes through clinical experience.
And what's worse is some of these studies don't involve even pregnant women. So it's
Right.
just an inference
Right.
between general surgery and those undergoing orthopedic surgery.
In many cases, there's not any data.
Did you come across anything about thrombophilia workups or any possible anabolic syndrome workup if they have preeclampsia prior to 32 weeks of pregnancy? Severe preeclampsia.
I didn't see anything about that, but like I talked about, the pregnancy complications of preeclampsia, they're slightly increased, but they need to have like clinical data too before you screen them. Like they need, in addition to the in addition to just having preeclampsia at early age as a sign of placental insufficiency, you just need a little bit more criteria before you would screen them.
Yes, yeah, but it's, well, this has been a long discussed topic, and I don't want to say most people. Generally, the yield is very low, and so most people would recommend not bothering to screen.
Would you just start the aspirin for the next
Yeah,
pregnancy?
that's perfectly
Right.
reasonable. Matter of fact, I don't see any reason why you don't start just regular, everybody on the baby aspirin.
Low bleeding risk
Yeah, well, exactly, there's no
Upset your
risk,
stomach.
and
and cost effective.
appears to be a
Cheap.
benefit.